Hi, everybody. It's good to be back again. My name is Don Buford. I'm an orthopedic surgeon in Dallas, Texas, and the title of this presentation is PRP versus bone marrow aspirate concentrate. What does the evidence support? I think by now, my good friend Rowan Paul has already given what I'm sure is an amazing lecture on the mechanism of action of BMAC. And what I'm going to do in this talk is go through where we have the best clinical evidence to use BMAC versus a different orthobiologic like PRP. So the three basic take-home pearls are that BMAC has MSCs and HSCs. Both of these stem cell types make biologically active proteins and cytokines. And even to this day, we're not quite sure which stem cell, whether it's MSC or HSC, which one is more important. The answer is they probably both are. They both make very similar biologically active things. And when you consider the HSC content in our marrow, you now have twice as many stem cells compared to just considering MSCs. Obviously, that's a little bit of a simplification, but it's not far off from the truth. Bone marrow aspirate concentrate has a much higher concentration of IRAP than PRP. After centrifuging bone marrow, we can raise the concentration of A2M, which is a known antiprotease. So let's look at some clinical examples where we have evidence that BMAC may be a preferential orthobiologic. Osteoarthritis is probably the single most studied application for BMAC where we have good clinical science. This slide is already a little bit out of date because as of July 2020, there were 18 clinical studies exploring the use of BMAC for osteoarthritis. That number is probably doubled now just in 2 years. So here's one example of a study exploring the use of BMAC for knee arthritis. This was published in 2018 by Kristen Oliver and David Crane and their colleagues. And with a single injection of BMAC, they noted that the benefit lasted through 2 years. And that's one of the real take-home clinical messages, is that for those of us using BMAC, I think most of us expect the clinical benefit to last longer than if we just used PRP. And that has been borne out in multiple studies that have been published in the literature. And this is just one of the early studies that showed that beneficial effect lasting longer than the typical PRP effect. If you remember from the PRP data, most of the well-done PRP studies show that the benefit starts to taper off somewhere between 10 and 12 months. Well, with BMAC, we're seeing that taper not start until we get to the 2-year mark at a minimum. This is a BMAC study that was published just last year. This is a Canadian study. And the interesting part of this study is that they had a small draw. So this was only 30 cc's of bone marrow. I think most of us doing these procedures now for a single knee would use 60 cc's, for example. The nice thing about this study is that even with a 30 cc draw, which is essentially half the dose, they had 70% responders, and the results lasted out to 1 year. And so my contention with this study would be, wow, if we do this study and double the dose, draw 60 cc's, maybe that then gets us to that at least 2-year mark for clinical efficacy. It was published in 2018 in the Journal of Translational Medicine. Lead author was Chris Centeno and his colleagues from the Regenerative Network. And the important part of this study is that the BMAC improvements were also shown to be maintained for 2 years, which is starting to become a recurring theme in well-done studies. This particular study is a little bit difficult to interpret in terms of a BMAC-only procedure because they also used a little bit of PRP and a little bit of platelet lysate and even a little bit of steroid. But the addition of BMAC may be the orthobiologic here that's responsible for lengthening the beneficial effect. I love reviewing this study from Philippe Hernigau because it's such an amazing study. This was a level 1 study with 140 patients, and he brought in people that had bilateral knee arthritis. One knee, he replaced the joint. The other knee, he did an intraosseous injection of BMAC into a bone marrow lesion. And what he found was that although there was a 1.2% per year risk of progression to a knee replacement in the knees that he injected, there was almost a similar 1% per year risk of revision of the knee replacement. And the other thing that was important clinically was that patients actually preferred their BMAC injected knee compared to their total knee replacement in this study. The lumbar disc is one of the other areas where we have pretty good evidence that BMAC is clinically effective. These three papers are all from the lead author, Ken Patine, and he had a dream team of PhD biologists, Matt Murphy, Richard Suzuki, and Ted Sand, that also helped on a couple of these papers. And what they found were a couple things that I think are clinically important. Number one is they did quantify the dose as best they could, and they found that patients tended to improve faster and to have better results when you got above a 2000 CFU per ml number. So this is one of the few attempts in the literature to quantify the BMAC dose and correlate it to clinical outcomes. The other thing is that all of the patients that entered this study had been told that they were candidates for discectomy. And yet at the end of 5 years, from a single BMAC injection into the disc, only 1 out of 4 had advanced to surgery at the 5-year mark. And so this is a disease modifying intervention in this example, and is one of the areas where BMAC really makes good sense. So this is data that I've been working on. We are getting closer to publication, but it is, if nothing else, it's evidence that our journal is blinded and unbiased, because as one of the co-editors of the journal, we have been through a lot of revisions on this article. And rightfully so. I think we're making it a better article once it hits print. It is unpublished data for that reason, but it is truthful data. If you thought I was lying, you probably shouldn't have asked me to give this presentation. And so long story short, from a single in-office injection, we documented that our patients' pain scores decreased from an average of 6 all the way down to 1.8, and that improvement in pain was durable out to 2 years. So once again, that magic number of 2 years when you use BMAC comes into play. The functional improvement that our patients received also matched this chart on the right that shows their pain scores decreasing. So we had a corresponding increase in functional improvement that was also durable out to 2 years. And so this slide is already out of date because there's been more publications in the last couple of years, but the average level of evidence for using BMAC for these diagnoses is 2.7. That's pretty good. And I say that because we published a paper a couple of years ago that showed that the average level of evidence in 6 of the top 10 orthopedic surgery journals is 3. And so for these conditions on this slide, the level of evidence for BMAC matches what we accept in orthopedic surgery for many of our surgical interventions and even many of our non-surgical interventions. So the number of studies being published is growing. The list of indications is growing rapidly. In 2020, this organization produced a position statement that a lot of people that are watching this video in this room probably participated in. I was one of them. I was led by Lax, of course. And the conclusion was that the evidence for knee arthritis at this point was level 2. The evidence for knee cartilage or bone marrow lesions was level 3. The evidence for disc injections was level 3. And at this point, the evidence for all other MSK conditions was level 4 or lower. And so if you want to stay really safe and kind of in your lane in terms of evidence-based BMC use, these are the things, or these are the areas where we have the most data. This slide and the position statement that was produced could be updated almost every 6 months. That's how rapidly the data is being published. And so it behooves all of us to keep our ear to the ground and go to meetings like this to get the latest information. Thank you very much for your attention. I look forward to one final virtual talk.